I call the meeting to order. Welcome to meeting number 9 of the House of Commons Standing Committee on Health. Today we meet for 2 hours to hear from witnesses on our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. Before I introduce today's witnesses, a few regular reminders for hybrid meetings. Today's meeting will be taking place in a hybrid format pursuant to the House Order of November 25th, 2021. Members attending in person in the room and remotely using the Zoom application. I think all of the members are or will soon be in the room, and the only people on Zoom are the witnesses. I'd like to take this opportunity to remind, I guess in this case, the people that are on Zoom, that the taking of screenshots or photos of your screen is not permitted. The proceedings will be made available on the House of Commons website. All health protocols prescribed by the public health authorities and the directive of the Board of Internal Economy of October 19th, 2021 will be observed and respected. Now, before we get to our witnesses today, I'm informed that we've got a couple of new members in the room, so I'd like to welcome Mr. Barrett, who replaces Mr. Berthod, and Ms. Goodridge, who replaces Ms. Kramp-Nyman. Certainly appreciate the time and the work that the outgoing members have contributed to the committee, and have every confidence that those shoes will be amply filled by their replacements. So, however, Mr. Berthod's departure means that we are left with a vacancy in the first vice chair role. So, pursuant to Standing Order 106 sub 2, the first vice chair must be a member of the official opposition, and I am now prepared to receive motions for the first vice chair. Mr. Lake.
I nominate Michael Barrett.
It's been moved by Mr. Lake that Michael Barrett be elected as the first vice chair of the committee. Are there any further motions? Seeing none, is it the pleasure of the committee to adopt the motion? I see consensus and declare the motion carried. Mr. Barrett duly elected first vice chair of the committee. Congratulations, sir. Now on to our witnesses and their opening remarks. To begin, both the Office of the Attorney General and the Public Health Agency of Canada has 5 minutes to make their opening statement before rounds of questions, which will occupy the remainder of our 2 hours. With us today, we have from the Office of the Auditor General, Andrew Hayes, Deputy Auditor General, Jean Goulet, Principal, Carol McCullough, Principal, Chantal Richard, Principal. From the Public Health Agency of Canada, Brigitte Jogo, Vice President, Health Security and Regional Operations Branch, Cindy Evans, Vice President, Emergency Management Branch, and Christopher Allison, Acting Vice President, Corporate Data and Surveillance Branch. Thank you all for being with us here today. We're going to proceed in the order listed on the notice of meeting, and so we're going to ask Deputy Auditor General Hayes to kick us off. You have the floor for 5 minutes.
Mr. Chair, thank you for this opportunity to discuss our reports on the Public Health Agency of Canada's response to the COVID-19 pandemic. First, I would like to acknowledge that this hearing is taking place on the traditional unceded territory of the Algonquin Anishinaabe people. Joining me today are Chantal Richard, Carol McCullough, and Jean Goulet, who are the principals responsible for the 3 audits that I will be discussing today. If I had to sum up our audits of pandemic preparedness, surveillance, and response, I would say that on the whole, the Public Health Agency of Canada was not as well prepared as it should have been to deal with this crisis. However, as we saw across organizations tasked with pandemic response that we have audited to date, public servants rallied and adjusted their activities in real time. In our March 2021 report that looked at the preparedness side, we found that not all emergency and response plans were up to date and tested at the onset of the pandemic. Data sharing agreements with the provinces and territories were also not finalized. In addition, the agency relied on a risk assessment tool that was untested and not designed to consider pandemic risk. As a result, despite growing numbers of COVID-19 cases in Canada and worldwide, the agency continued to assess the pandemic risk as low. The Global Public Health Intelligence Network did not issue an alert about the virus that would become known to cause COVID-19. Once the pandemic hit Canada, the Public Health Agency of Canada and the Canada Border Services Agency worked together to implement border restrictions and quarantine requirements. However, we found that the Public Health Agency was unprepared for a nationwide quarantine. For example, it struggled with a paper system to gather travelers' information. This hindered efforts to follow up with individuals at risk of not complying with quarantine orders. As a result, the agency did not know whether 66% of incoming travelers who were required to quarantine in fact did so. Our December 2021 report showed an improvement in the administration of the 14-day quarantine orders since our initial audit, partly because the agency had moved to an electronic system to collect travelers' information. However, between January and June 2021, the agency was still unable to confirm whether 37% of inbound travelers complied with quarantine orders. That is still a large number of people to lose sight of. Ce deuxième audit a également examiné.
This second audit also looked at the enforcement of new testing orders. We found that the agency was either missing or unable to match 30% of COVID-19 test results to travelers arriving in Canada. In addition, the agency lacked records for 75% of travelers arriving by plane, making it impossible to know whether these travelers quarantined at authorized hotels as ordered. Our audit of personal protective equipment and medical devices, released in May 2021, also showed that the Public Health Agency of Canada was not as prepared as it should have been to deal with the surge in requests for equipment from the provinces and territories triggered by the pandemic. This was because the agency had not addressed long-standing issues affecting the management of the National Emergency Strategic Stockpile, though these had been raised in audits and reviews going back more than a decade. Despite these pre-existing issues, the agency worked with Public Services and Procurement Canada and Health Canada and adapted its activities to help meet needs for personal protective equipment and medical devices across the country. For example, the agency shifted to a bulk purchasing strategy and improved how it assessed needs and allocated equipment, among other changes. If there is one overall takeaway from these audits, it is that long-standing known issues such as outdated systems and practices must be dealt with. This would allow government organizations to be better prepared for unforeseen events such as this pandemic. Mr. Chair, this concludes my opening remarks. We would be pleased to answer any questions the committee may have. Thank you.
And now, on behalf of the Public Health Agency of Canada, we're going to hear from Ms. Diogo, and I hope I have not butchered your name. Welcome to the committee. You have 5 minutes.
Thank you, Mr. Chair. My name is Brigitte Diogo, and as you mentioned, I'm the Vice President for the Health Security and Regional Operations Branch. I am happy to be here today to have the opportunity to speak to the committee. I am joined by my two colleagues, Cindy Evans, Vice President, Emergency Management Branch, and Chris Allison, Acting Vice President, Corporate Data and Surveillance Branch. As the pandemic approaches the 2-year mark, we recognize the resilience of Canadians and the sacrifice everyone had to make in these unprecedented times to minimize the impact of COVID-19. We are proud to say that the agency has worked throughout the pandemic to take the actions needed to protect the health and safety of Canadians. La pandémie n'est pas terminée.
The pandemic is not over, and the agency must remain nimble and ready to respond to new risks in an appropriate and proportional manner. I'd like to take a few minutes to talk about the Public Health Agency of Canada's efforts since the onset of COVID, in close collaboration with federal, provincial, and territorial partners, as well as learning from the experiences of our international counterparts.
4 months, the Public Health Agency has been on the front lines for the federal response to COVID-19. The agency has taken an evidence-based, multi-layered approach to public health measures, which have been adapted as we learn more about the virus and the Delta and Omicron variants that have emerged. A year ago at this time, we were in the early stages of getting vaccines into the arms of Canadians. Thanks to a solid immunization strategy and federal, provincial, and territorial governments working together, as of February 25th, more than 80% of the total population is fully vaccinated, one of the highest rates in the world. And more than 55% of the population over 18 years of age have received an additional dose, and clinics are continuing to offer boosters. Les personnes non vaccinées qui contractent.
With unvaccinated individuals who get COVID being 4 times more likely to be hospitalized than fully vaccinated individuals, it is clear that the vaccine rollout helped to reduce severe illness and save lives. Throughout the pandemic response, the Government of Canada has adjusted its border measures as new data and scientific evidence became available, and in response to the epidemiological situation both in Canada and internationally.
I recognize that border measures can pose challenges for individuals and families, but these measures help to prevent new chains of transmission in Canadian communities, protect Canada's healthcare capacity and vulnerable populations. As the Auditor General noted, the agency was able to successfully adapt to secure personal protective equipment and medical supplies. Tout au long de la pandémie,
throughout the pandemic, science and collaboration have been fundamental keys to inform the agency's efforts. We have gained much scientific knowledge about this novel virus and its variants to inform our advice and actions, and we have worked closely with other federal agencies, provinces and territories, Indigenous partners, and academic and international counterparts on various innovative research initiatives. For example, the agency collaborated with other levels of government, including municipal governments and academia, to establish a pan-Canadian network for wastewater surveillance to monitor for early warning signals of COVID-19 and its variants across the country.
En conclusion,
in conclusion,
leadership, communication, science, surveillance, and vaccination have been critical as we manage the pandemic. These same factors will continue to be key as we move forward. While significant strides were made over the course of the pandemic, the agency acknowledges that it was not as prepared as it could have been prior to the pandemic, and that there are lessons to be learned. We remain committed to responding to the Auditor General's recommendation in full within the established timelines. As the Omicron wave continues to recede, we need to recognize that COVID-19 will be with us for the foreseeable future. The Public Health Agency of Canada will continue to incorporate the knowledge and expertise it had gained towards our efforts for the long-term sustainable management of COVID-19 and to better prepare for any future public health crisis. My colleague and I will be happy to take your questions. Thank you.
Thank you very much, Ms. Diogo. We're going to begin with rounds of questions now, starting with the Conservatives. Dr. Ellis, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for their opening statements and for appearing here today. For Mr. Hayes on the Auditor General side, the Global Public Health Information Network, Intelligence Network, you stated there was no alert back in 2020. Sir, could you tell us, please, the budget for the Global Public Health Intelligence Network?
That may be a question best directed to the Public Health Agency. I don't have numbers about their budget for the Global Public Health Intelligence Network.
Anybody on PHAC know the answer to that?
Mr. Chair, we'd be pleased to come back to the committee with that specific number. I don't have that number in hand in front of me. Thank you.
Okay, so nobody knows the budget. Thank you. For the same outfit, we talked about things were without an alert. Can you name 3 changes, sir, that happened over the last 2 years to the intelligence network to make it better?
Again, I would ask the Public Health Agency if they might have an answer to that. In our audit, we noted the weaknesses in not providing an alert, and identified that over the course of the last few years, the process has changed for the approval of alerts, and there have been considerably less since the process changed.
Can anybody name 3 changes that have been made?
Thank you, Mr. Chair. With respect to the Global Public Health Intelligence Network, we thank the Auditor General for her attention to this important function. A number of changes have taken place since the audit and since the independent expert panel. We've addressed an action plan. We've developed an action plan to address all of the recommendations. We have improved and streamlined the decision-making process for issuing GFIN alerts and other GFIN products and processes. With respect to the technology, we have migrated the GFIN system to a new cloud function, and as well have moved forward to hire a technical advisor and invested in the training and development. So those are a number of the changes that have been initiated since the time of the audit. Thank you.
Thank you. Apparently, if I understood Mr. Hayes correctly, 75% of information for travelers coming into this country was not available. Can anybody tell me why we continue with border measures with such a leaky border?
Mr. Chair, thank you for that question. And again, I would like to take the opportunity to thank the Auditor General for the report. We have made several improvements to the way we collect data. In particular, since the first report of the Auditor General, we have moved from a paper system to an electronic collection of information, and are able to share information with the provinces and territories much faster. And we have made some changes internally to improve our compliance and enforcement approach. Thank you.
So to continue on with that, it's interesting, if I'm correct, rapid antigen tests in asymptomatic individuals have a sensitivity of about 44%. Plus, we're only capturing about 25% of the data in travelers. Can anybody tell me why we continue to use a system like that penalizes Canadians?
Thank you, Mr. Chair. Until recently, the only requirement that we have for people arriving from abroad is to use the molecular test. The change to allow for antigen tests is a change that starts today. With regard to the domestic testing, whether it's testing on arrival or testing on day 8, this is based on a molecular test PCR technology that we have been using. Thank you.
Mr. Chair, that's fine, and I thank you for your answer. I guess my point is we're moving to an antigen test that is 44% sensitive in a system that's only collecting 25% of the data. Why do we do that? What's the benefit to our border security? To me, the math doesn't add up. That means 56% of people are asymptomatic coming into the country, could be told that they have a false negative test, and we're only collecting 25% of the data. That mathematically makes no sense to me.
So thank you for that question. The change has been made in recognition of the high vaccination rates that have been achieved, and recognizing that this is a change that we just implemented today. The agency will continue to monitor the results and determine whether other changes will need to be made to the regime. Thank you.
I thank you for that, Mr. Chair. I guess I want to reiterate the fact of why did we make a change to the rapid antigen test that we know is not sensitive in asymptomatic individuals, because if you're symptomatic, guess what? You're not getting on an airplane. So the question remains, why would we recommend this change? Why would we keep it at all? That doesn't make any sense to me. I guess it's the third time I'm asking the same question, so I guess why? I really would like an answer.
Well, while the test, Mr. Chair, while the antigen test is not as sensitive as the PCR test, it is still a test that has seen a lot of improvement over time. And the department feels that based on what we have learned from antigen tests, that this is an option that we would like to offer to Canadians who are traveling and returning from travel abroad. In particular, the fact that when people arrive in Canada, they are still subject to, will be subject to mandatory testing, and the Public Health Agency will continue to collect data to determine whether adjustment would need to be made to that regime.
Thank you, Ms. Diogo. Thank you, Dr. Ellis. Next, Mr. Van Couverden, please, for 6 minutes.
Thank you, Mr. Chair, and thank you so much to to all of the witnesses for joining us here today. I'd also like to welcome our two new members, MPs Goodridge and Barrett. Welcome to HESA. Thank you for being here today, and I also want to thank you for all of your extraordinary work over the last 2 years. This has been a relentless 2 years, and all of our staffs have been exhausted by it, and I imagine that you and your staffs have been too. So I just want to acknowledge how challenging it's been, and thank you for your extraordinary efforts. I have two questions today, and both will focus on the Public Health Agency of Canada. Canada is fortunate to have one of the lowest death rates of all of our peer nation countries. While it's less productive to focus on how our system proved to be resilient and supported the health and safety of Canadians. I'm wondering why, from your perspectives, given that we have seen this pandemic, unveil quite a few gaps in our healthcare system and some issues that we need to address as soon as possible. It's also true that from a performance perspective, Canada has demonstrated fairly good resilience against COVID-19. I suppose we all have our reasons to believe that to be the case, but I would like to hear from the Public Health Agency of Canada first on why they believe our country has been fortunately among the countries with a lower death rate than many others.
Mr. Chair, thank you for that question. I think one of the primary influences that we've had in Canada has been our ability to very rapidly enact the governance structure that sits under the FPT, Public Health Response Plan for Biological Events. And that allowed us to very quickly put in place an effective FPT governance for COVID-19, and bringing together the strength of the collaborative effort of the provinces and territories in all aspects from the beginning of January, I think was a very effective measure for Canada and had a very significant influence. I don't know if my colleagues with respect to any of their surveillance or borders would have anything to add in that regard.
Thank you, Cindy. I could add on, it's the layers of protection that we have built in place, the vaccination, but also the effort made to ensure that we are monitoring the importation risks and taking action as they become evident, and as well the collaboration with provinces and territories had contributed to a pan-Canadian effort to really mitigate the risk, vaccination being at the core of progress that we have made here to deal with and cope with the pandemic.
Thank you. Just as a follow-up to that question, I have one more. Would be if you could, put your finger or isolate one major gap or one major failing that unfortunately costs Canadian lives, where would that gap be? I know that it's far more complex than just one issue, but what is a major one that we could address?
Mr. Chair, thank you for that question. I think one of the critical lessons learned for Canada has been with respect to the domestic self-sufficiency in regard to particularly personal protective equipment. So we saw some fantastic leaning forward by manufacturers in Canada, from everything from face shields to hand sanitizers, to quickly mobilize manufacturing in Canada, where we saw a fiercely competitive global market. But in the face of that type of competitive nature, we need to build on and learn from the domestic manufacturing that we've put in place today to better situate Canada for the future. Thank you.
Thank you. Well, I think we're all grateful to see an increase in domestic production of both vaccines and PPE, so thank you for that answer. Moving on a little bit, again to PHAC, I'm curious to what degree the Public Health Agency of Canada agrees with the Auditor General's assessment, findings, and recommendations, and what aspects of it they feel are worthy of conversation, perhaps?
So thank you. I could start and then turn to my colleague. I would say that as we went forward to respond to the pandemic, a number of programs were stood up very quickly. And so we absolutely welcome the reports and the recommendations from the Auditor General. There is no question that whether we could have been better prepared. The answer is absolutely yes. Have we learned from the lesson, and are we making adjustment as we go? The answer absolutely yes. So we would continue to implement the recommendations. I would say that from a border management perspective, one of the points that the Auditor General raised was about the electronic system and our quarantine management system. And so how do we position ourselves and be ready for future pandemic is one that we are very much working on and keeping in mind. Thank you.
Thank you, Ms. Diogo. Mr. Van Couverden, suite la parole est à Monsieur Thériault pour 6 minutes.
Mr. Thériault, you have the floor. Thank you, Mr. Chairman. I'd like to start by thanking today's witnesses for enlightening us and giving some information about the pandemic, updated information, so that we can take a look at solutions and so that we can deal with the next incident of the sort. My first question is for the Auditor General. In report number 13, you clearly state that a number of difficulties were experienced with respect to the follow-up and surveillance of quarantine measures for temporary foreign workers. You raised the fact that some of these inspections for quarantine were imperfect, incomplete. There were some delays. There were a number of problems in the agricultural sector. What do you attribute these problems to? And do you not believe it would have been more effective when it comes to pandemic control and any risk of any further outbreaks, that quarantine management be managed by the government as soon as these workers arrived, and then afterwards they could have gone to their farms or where they were going to work? Wouldn't this have avoided the problems that occurred?
Merci pour la question.
Thank you for the question. I'm not in a position to comment on the government's political choices, but with respect to your first question, I would say this. Agreements between the federal government and the provincial and territorial governments were significant. They needed to be completed, and the information to be received needed to be accurate. It had to be accurate information in order to manage a pandemic. Now, with respect to the quarantine measures, I would say that the information provided by travelers is so important to identify quarantine measures that should be followed by travelers. here I was actually talking about temporary foreign workers specifically here. Sorry, I hadn't understood. Actually, you're raising, you raised an issue about managing inspections on site, and based on your analysis, so you're attributing these problems to what is my question? And I realize that you're not here to criticize political choices made by the government, but based on your analysis, wouldn't it be easier, simpler, to start off by making sure that these workers were taken, were dealt with in a way by the federal government, and then that they would then move to their facilities? Yes, sorry, I had misunderstood. With respect to that report, our findings were that the department had not done high-quality inspections. 2 years there were temporary foreign workers that came to the country for a 2-year period, and we did not see a huge improvement in the results. That was a problem with the way in which these departments manage inspections. Again, I cannot say that another policy would have been better for us. For us, it was important that the inspections be of good quality. Okay, all right. So, question for the agency. I would imagine that you recognize the shortcomings raised in the Auditor General's reports. Now, for the upcoming months, as to the future, what are the lessons learned? What should be done to guarantee proper health measures while simplifying things when it comes to temporary foreign workers, inspectors, employers? Thank you, Mr. Chairman, for the question. I would say that the current scheme or regime with respect to temporary foreign workers is managed by another department. Clearly, our agency worked closely with the SDC, which is the department, on this program. The option as to how to manage these workers' quarantines, well, that decision was made in concert with the provinces and territories. Clearly, when you think of risk, the risk of infection, the fact that people arrive at a place where they have to quarantine at their final destination, that would seem to be the best way we can think of managing risk, even after arrival in Canada. So yes, we work in concert with ESDC, Employment Social Development Canada, to see how we can improve the arrivals for these workers, how to work with private sector partners to manage risk and make sure that these workers... Oh, the sound just cut out, unfortunately.
Thériault.
Thank you, Mr. Thériault.
For 6 minutes.
Thank you. To Public Health Agency, the Global Public Health Intelligence Network has been part of Canada's contribution to the World Health Organization, which described GFIN as, quote, a cornerstone and, quote, the foundation of global early warning. They said approximately 20% of the WHO's epidemiological intelligence had come from GFIN before it was silenced effectively in 2019. In that year, we're told that a department edict was issued that all such alerts from GFIN had to be approved by senior managers. My question is who issued that edict, and has it been reversed?
Apologies, a little technical difficulty. Thank you, Mr. Chair, for the question. So the member is correct. 20% of the information that is fed into the World Health Organization's epidemic intelligence does come from the Global Public Intelligence Network. But I would like to clarify for the committee, at no point was the Global Health Public Intelligence Network silenced. There are a number of products that do come out of this program, and the feed to the WHO is one of them, as are the GFIN daily reports, GFIN alerts, as well as a platform.
I have limited time, I'm sorry, but my question was about the department edict that all such alerts had to be approved by senior managers. That was the edict, was it not?
So, Mr. Chair, under the independent external panel review, it was clarified there was no documentation to identify a specific edict, but nonetheless, the department did undertake to put in place clear standard operating procedures with clarity in terms of the level of sign-off for alerts, which are done not at a high senior management level. So we brought clarity in terms of the criteria that are used for reports, which align to the WHO's public health emergencies of international consequence.
Then can you explain to me why an emergency alert was not issued by GFIN about COVID-19?
Yes. So what the GFIN review did identify is that the GFIN program did what it was intended to do. So the GFIN program did identify the outbreak in Wuhan on December 30th of 2019 and included that in a report on December 31st, as well as a special standalone report. At that time, the information was already circulating with international partners, so adding an additional alert would not have provided additional support to the international community. The independent review panel did confirm it saw no evidence suggesting an earlier identification of the GFIN was possible and that it would not have impacted on the actions taken by the Public Health Agency. Thank you, Mr. Chair.
Thank you. Now, the Auditor General's report, you heard him here today, summarized it. A number of scathing reports were issued, and he just stated today that the problems arose because the PIAC had not addressed long-standing problems going back a decade. And if there was one overall takeaway, he said that long-standing known issues must be dealt with. My question to PIAC is, who is accountable, who has been held accountable for not addressing the problems going back a decade and for long-standing known issues not being dealt with?
Mr. Chair, thank you for the question, and we thank the Auditor General for the attention to these important issues. A number of steps have taken place, and our focus at this time remains on continuing the fight against COVID-19 and serving Canadians, and we've laid out a path towards addressing the recommendations from the Auditor General across a number of the audits, and certainly we are here today to answer questions in terms of that forward-looking plan. Thank you.
I don't know if you understood the question. The question was who has been held accountable for those conclusions. And if you don't know, you can just say you don't know.
Mr. Chair, the Public Health Agency of Canada accepts the recommendations from the Office of the Auditor General, and we thank her for her attention to these important issues. Thank you.
Now, one of the reports noted limited public health expertise, including epidemiologists, psychologists, behavioral scientists, and physicians at senior levels. The audit also found a lack of emergency response management expertise and capacity within the agency. What steps has PHAC taken since the publication of this report to ensure that the agency has the expertise and capacity to fulfill its mandate?
Mr. Chair, thank you for the question. The Public Health Agency has increased its resources over the course of the pandemic, and that's with respect to epidemiologists, physicians, as well as a number of laboratory technologists. Certainly, we are facing a pandemic that we haven't seen the nature of in 100 years. In working with our colleagues in the jurisdiction, similarly, both the magnitude of the response as well as the length of the response certainly created pressures in terms of the types of resources that we require. We are pleased with the recommendations from the Office of the Auditor General, and certainly moving forward in terms of strengthening the Public Health Agency, both with respect to our organizational structure to bring clarity and attention to these areas, but as well in terms of our training programs within the emergency management plans. We've been quite fortunate in terms of two programs, the Canadian Field Epidemiology Program, which formed a key support during the COVID-19 response, as well as the Canadian Public Health Service. So our ability to utilize those particularly epidemiological resources has certainly served us well, and we will be looking to bolster programs like those as well as others going forward. Thank you.
Thank you, Ms. Evans. Mr. Davies. Next, Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair, and I thank everybody for appearing here before the committee. And like my colleague said, we have limited time, so some of these questions may be simple yes or no's or numbers. The Prime Minister has stated, this is for PHAC, that 90% of Canadians have double vaccinated. Your numbers seem to be different from that. Can someone please tell me how many Canadians over the age of 12 have had 2 vaccines? Just a number.
Mr. Chair, although the vaccine rollout is managed by the Public Health Agency, those officials are not here with us today to respond to the Office of the Auditor General report, but we'd be pleased to follow up in writing with the committee on that question. Thank you.
Fair enough. For the PHAC again, Novavax. Do we have the rights to produce Novavax domestically?
Mr. Chair, respectfully, the officials here today, it's outside of their purview to speak to the vaccine rollout program. So certainly we undertake to provide appropriate information back to the committee in writing.
What about antivirals? Do we have the rights to produce them domestically?
Mr. Chair, with respect, the officials today, it's outside of their purview to speak to the antiviral file. Again, we'd be happy to provide appropriate information to the committee in writing.
Okay, these are all interesting answers. What about rapid tests? How many of those are made in Canada?
Mr. Chair, officials are here today prepared to answer questions with respect to the Auditor General's audit. So unfortunately, we don't have an official today who could speak to that. We'd be happy to follow up with the committee in writing in response to those questions. Thank you.
Okay. What about border measures? We've often heard that border measures, we've had some struggles with them. We've talked about the percentage sensitivity of rapid tests. We've talked about the leakiness of data. And now we also know that everywhere in the world there's COVID. So do border measures, closing the borders, work?
Mr. Chair, thank you for the question. The border measures are only one part of the government's response to the pandemic. Certainly, based on our data looking at positivity rates, we have been able to monitor importation risks, and all that contribute to limiting risk to Canadians. And so my answer will be yes, they are not like everything else. They need improvements and they need continuous adjustment, but they have certainly been effective in contributing to slowing down importation risks to Canada.
Okay,
Thank
interesting. Yeah, I guess the other question I have is, do we have an expert here today about Novavax? Maybe that's easier.
No, Mr. Chair.
No Novavax. Okay, and no antiviral person, no rapid test person, and do we have someone who knows anything about PPE?
Mr. Chair, I'd be pleased to answer questions regarding the National Emergency Strategic Stockpile and PPE.
Okay, that'd be great. That being said, how many manufacturers in Canada do we have of PPE, including gloves, gowns, and masks?
Mr. Chair, thank you for the question. I can't speak specifically to the number of manufacturers. I will say that 70% of the public health agency contracts for the N95 respirators are domestic. 50% of the surgical masks that are procured by the public health agency are domestically manufactured. 100% of the face shields are procured by fact are domestically manufactured, and 25% of the disposable gowns have been domestically manufactured. Thank you.
And along that same line, Mr. Chair, we said 50% of masks and 25% of gowns. Can the officials from PHAC tell me where the other percentages are made?
They would be sourced internationally. I don't have the specifics on each of the other contracts. They would come from a number of countries, including the U.S. Thank you.
And can we have that in writing, please? Which countries they come from? Will you follow up on that, please?
Mr. Chair, we'd be pleased to provide available information to the committee in writing. Thank you.
Thank you.
Thank you, Ms. Evans.
Point of order,
Thank
Mr.
you.
Chair.
Yes, go ahead, Mr. Lake, on a point of order.
Yeah, many commitments have been made to get further info. I just want to ensure that as a committee, we follow up on those commitments and get that information that's been promised. Thank you.
Yep. Okay, Dr. Pawlowski, please, for
Point of
5
order,
minutes.
Mr. Chair. Point of order.
Yes, Mr. Davies.
May I just add to Mr. Lake's suggestion by saying that we have that information within 7 days?
Ms. Evans, is 7 days a reasonable turnaround for the information that you've undertaken to provide?
Mr. Chair, certainly we'll undertake to provide all information possible within that 7-day time frame and
Thank you.
follow up. Thank you.
Thank you, Mr. Davies and Mr. Lake. Dr. Pawlowski for 5 minutes.
Thank you. The Minister of Health requested an independent review of Canada's global public health surveillance system, the Global Public Health Intelligence Network. So I wanted to ask something about the GPHIN. Now, it seems that it was working at the time of COVID, and I think someone from PHAC told us that, in fact, there had been a warning that it had been detected that there was an outbreak of pneumonias in China. However, the problem seems to be from the report that nobody was listening. If I can make the analogy from medicine, there was a monitor on the patient, but nobody was looking at the monitor. If I can quote from the report of the independent review, they said a governance structure was in place for oversight of surveillance activities from April 2007 to March 2019. However, key leadership responsibilities were not redistributed following the elimination of the position. So later on, they talk about the Center for Emergency Preparedness and Response lacked information on how information on events is shared, particularly with senior management. Later on, they say it was not always clear who is responsible for what in the flow of information, risk assessment, and chain of decision making. Again, to use that analogy, there was information coming in. You did have a monitor on the patient, but nobody was watching the monitor. They do. In that review, the independent review, they suggest more effective links between the Global Public Health Intelligence Network and Public Health Agency of Canada, the need for a whole-of-agency approach. What has Public Health Agency of Canada have they done in order to address this shortcoming?
Mr. Chair, thank you for the question. The external independent panel announced by the Minister of Health November 2020 released its final report in July 2021. A number of the key findings are, as has been mentioned, the GPHIN did what it was designed to do, and it also confirmed that it had never been shut down. So the GPHIN did identify the outbreak in Wuhan and allowed FAC leadership to take immediate action. So I would say the leadership was listening and did act immediately. We notified officials across the government, followed by all the public health officials across Canada by January 2nd. So very early on, the system was sensitized. So our response effectively began on the first days of 2020. The panel saw no evidence that any earlier identification by the GFIN of the outbreak would have been possible based on their assessment of other open source data systems. There were 64 recommendations from the independent panel on 3 different themes. So GFIN roles and purpose, the organization and flow of information, as well as technology. And as has been stated, there were some broader recommendations, including looking at broadening our approach to risk assessment. And in that regard, the agency has implemented in December of the previous calendar year a Center for Integrated Risk Assessment so that we can move forward on those important recommendations. I'll just pause and see if my colleague, Mr. Allison, would like to add anything with respect to the broader surveillance question that you've raised.
Thank you, Cindy, and thank you for the question, Mr. Chair. As Cindy mentioned, not only the Center for Integrated Risk Assessment being stood up in December of 2021, but also the development of the a new branch, the Corporate Data and Surveillance Branch that is responsible for working with partners, including the GFIN network, and looking at things a bit more holistically, seeing how we can improve our overall surveillance, data integration processes, and seeing how we can get to the better public health outcomes that we're all looking for. CIRA, the Center for Integrated Risk Assessment, is starting to look at these issues now and is developing the frameworks and processes that we need to move forward and do better, both through this pandemic that is ongoing and also into the future.
Thank you. I want to get in a quick other question. I think Public Health Agency of Canada ought to appreciate the essential work that GFIN does. I think Public Health Agency of Canada must know that the international health regulations are being reviewed, and WHO has initiated a process in writing a new treaty on infectious disease, and certainly must appreciate the importance of these kind of early warning systems, and the fact that many poor countries do not have the resources to do such monitoring. Certainly, many people feel that an essential part of a revision to the international health regulations and a new treaty on control of infectious disease would require developed countries to financially assist developing countries in doing such monitoring. Has PHAC considered this issue, and does it have a position with respect to it? Thank you.
Very briefly, please.
Thank you, Mr. Chair. As I mentioned, GFIN continues to be an important source of information. 20% of the feed into the World Health Organization's open source data system. We are very interested in the international discussions on updates and potential changes to the international health regulations, and public health agency officials will be participating in those discussions and certainly actively interested to follow those. And we agree and with the independent review panel's recommendation that the GFIN should both continue to include a domestic and international objectives with regard to providing that information. Thank you.
Thank you, Ms. Evans and Dr. Pawlowski. Suite, M. Thériault pour 2 minutes et demie.
Merci, Monsieur le Président. Dans le dernier rapport...
Thank you. In the auditor's last report, the agency did not have a register or registry for 75% of arrivals to Canada. So the agency did not know if those who should quarantine in a hotel had done so. So there were a number of problems when it comes to these quarantines. Now, given these failings, should we gather from that the measures you expected to take to protect us were actually a facade for show rather than actual public health measures? Thank you, Mr. Chairman, for the question. Indeed, you mention the findings of the Auditor General's office. Now, with respect to the agency, we implemented a number of interventions at different stages prior to arrival, when people arrive in Canada, and post-arrival. Now, with respect to travelers who arrived and had to go to a hotel, we developed the program so that people could comply from the start. I'm sorry. The follow-up, this limited follow-up, this failure to be able to really follow up on quarantines. Who actually did quarantine? What is that failure due to? Is it lack of resources? And if it's not, then what was the cause of it? And if you identified the cause, now what are you doing to rectify this situation? Or what will you do to correct it? Briefly, if you can, says the chair. Yes, I was going to say that based on our data, we did not arrive at the same conclusions in the Auditor General's office with respect to non-compliance when it came to the, but you had a registry. We had asked for hotels to provide information on people who arrived at the hotel. And it is this failing that the Auditor General mentioned, but we knew from the start who was sent to the hotels. All of the people who arrived who were non-compliant, in the sense that they did not have a hotel reserved, didn't have a reservation, all those people were reserved to the agency at the airports. The agency had increased its resources to make sure that we could help travelers comply. So we had worked with the airports to make sure that people could make hotel reservations. And we contacted 100% of those who were found to be positive, because people had to go to the hotels, wait for the results of their tests. The agency contacted each person to make sure that those individuals understood the quarantine requirements. So yes, there are improvements that could be made. We are currently working on our system on border management and quarantine management. Thank you. Thank you, Ms. Diogo and Mr. Thériault.
Please, for 2.5 minutes.
Thank you. The Auditor General's May 2021 report on securing personal protective equipment and medical devices found PHAC was not as prepared as it should have been to respond to the COVID-19 pandemic due to, quote, long-standing unaddressed problems with the systems and practices in place to manage the National Emergency Strategic Stockpile. He pointed out that the unaddressed federal stockpile issues had been brought to PHAC's attention through a series of internal audits dating back to at least 2010. On a scale of 1 to 10, 1 being terrible and 10 being perfect, how would you describe the current state of Canada's National Emergency Strategic Stockpile?
Mr. Chair, thank you for the question. We've made significant progress in terms of situating ourselves to be ready to respond to the current COVID situation. We now have an 8-week stockpile supply of key personal protective commodities, and that includes N95 respirators, surgical masks, gloves, face shields. We've been able to actively respond to 379 requests for assistance from the provinces and territories and other government departments to support them with necessary medical equipment and supplies. As well, we procured over 40,000 new biomedical devices to support the increased needs given the clinical.
Sorry, Ms. Evans, I have limited
response.
time. That's why I framed my question very precisely. Those numbers are meaningless to me unless I know whether that's good or not. For instance, how many weeks of supply did we have in our stockpile at the time the Auditor General said we were not doing a good job? You just said we have 8 weeks now. What did we have then?
So working with the provinces and territories, we were able to put in place a supply and demand model that helped us to establish what were the key burn rates that were in effect during COVID-19, and worked with the provinces to determine both the needs for their stockpiles as well as for the Public Health Agency. So certainly we had personal protective equipment
I'm
was
sorry, I'm
not
going to go
a
somewhere else. I'm
commodity.
sorry. This is, I have to say, it's unacceptable to get that kind of dissembling to direct questions from the Health Committee. I just must say, for the record. Ms. Diago, what is the current state of knowledge on an infection-acquired immunity?
Okay. Short answer, please, Ms. Diago.
Well, thank you for the question. I'm not a scientist. I have to the department responding in writing to that question.
Thank you, Mr. Davies. Next, Mr. Barrett, please, for 5 minutes.
Thank you, Chair. Thanks to the witnesses. Through you, Chair, to the witnesses at the Public Health Agency of Canada, a number of Canadian provinces have released step-by-step plans that detail their exit from COVID-19 or an end to COVID-19 restrictions in their jurisdictions. Has the Public Health Agency of Canada prepared a plan like that?
Thank you, Mr. Chair, for the question. The agency is working with other government departments on and in consultation with the provinces and territories about a phased approach to adjusting the public health measures. We are looking to inform that those discussions with what we have learned from the science and from data. But currently, the border measures and the public health measures are being how to change those measures are being discussed with provinces and territories.
Okay, thanks for the answer. Again, through the chair, what are the benchmarks that the Public Health Agency of Canada has established that are being used to justify the current restrictions or the change to restrictions at port of entries, to go back to the response from the previous official, Mr. Chair?
Well, in terms of benchmark, we certainly monitor the epidemiology, whether it's in Canada or elsewhere. We are looking at importation risk, looking at the result of our testing regime, looking at the positivity rates, for example, in the border testing, to determine whether there be adjustment to the measures. We're certainly looking at the domestic level, looking at vaccination, and as well looking at impact on the healthcare system in Canada. So those are some of the elements that goes into the modeling that is done to determine whether we have to make adjustments. Thank you.
Okay, well, I appreciate the answer, Mr. Chair. I think that specifically knowing what the benchmarks are would help inform the Canadian public and certainly members of this committee, and that's what we've seen with some of the provinces with respect to the step-by-step that they've laid out, and knowing what those metrics need to look like. Is it a 100% vaccination rate? Is it a 0% test positivity rate? What are the numbers that have been identified? And so through you, Mr. Chair, just very quickly, I'd ask if the witness would undertake to provide what those benchmarks are to the committee in writing.
Yes, Mr. Chair, we can provide that information.
Okay, thank you, Chair. My next question is with respect to the requirement for proof of vaccination at our ports of entry. I want to refer to a statement on the 10th meeting of the International Health Regulations Emergency Committee regarding the coronavirus COVID-19 pandemic from 19 January 2022. That's from the World Health Organization. It lists and identifies actions that are critical for all countries. And one of those items listed is that countries not require proof of vaccination against COVID-19 for international travel as the only pathway or condition permitting international travel, given limited global access and equitable distribution of COVID-19 vaccines. And it continues, but I'll stop quoting it there and just ask, through you, Chair, if the witnesses can tell us why it is that that information is not been, that recommendation has not been adopted, and if Canada is going to move away from the requirement for proof of vaccination as, again, one of the other steps that they're going to take towards sunsetting or ending the federal requirements.
Okay, we're out of time,
So-
but we'll allow a brief response there, please.
Thank you, Mr. Chair. There is no plan to move away from that requirement at this time. The vaccination has been a foundational piece in reopening to international travel. And at this time, it's something that we are retaining. Thank you.
Thank you, Mr. Barrett. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses being with us. My question is to Ms. Diego. As the official response for the PHAC's regional branches, could you speak your agency's relationship with various health systems of the provinces and territories? What were the challenges in inventory control and tracking equipments?
Thank you, Mr. Chair. I believe that's a question for my colleague, Sydney Evans.
Thank you, Mr. Chair, for the question. Early on in the pandemic, there were some challenges with respect to the provinces and territories being able to very quickly identify their current holdings of personal protective equipment. So in that regard, the Public Health Agency moved forward quickly in collaboration with our partners at Public Safety and Procurement Canada to engage in terms of bulk procurement so that we could secure for Canada the personal protective equipment needed. And then we had a very transparent allocation framework where 80% of those procurements were moved quickly as they come into the province and territories, with 20% being held back for the National Emergency Strategic Stockpile. We developed systems to collect information throughout the pandemic in terms of what were the holdings of the jurisdictions to help understand where might be the pressure points and where we might be at greater risk in terms of the supply coming in. And we're fortunate to have very effective governance structures, including the Logistics Advisory Committee, where we could discuss the challenges and as well to facilitate sharing across the jurisdictions where there were pressure points as Canada was moving forward to increase its holdings of the personal protective equipment. Thank you.
And to follow up a question, Ms. Evan, what can be done to get the better data surveillance, and what is the timeline to identify the gap to be fulfilled?
So I'll turn to my colleague, Mr. Allison, with respect to the Pan-Canadian data strategy, but I will say with respect to the National Emergency Strategic Stockpile, the work that was done to create a Pan-Canadian supply and demand model was very effective, and that modeling served us well, and that is work that we will continue on in our work with the provinces and territories. As well, we were able to put in place data systems which allowed them to help to see which shipments were coming when, and that also allowed for good alignment of inventory systems across. But with that, I'll allow my colleague to speak to you about the Pan-Canadian data strategy.
Thank you, Cindy, and thank you, Mr. Chair. In terms of data gaps, this is a broad, complex issue given the way that health is a shared responsibility across provinces, territories, Indigenous communities, and the federal government. And the solutions to this there are no silver bullets. The work has been ongoing to find a way to make sure that public health data is reliable, timely, and relevant, that data is getting to where it needs to be. And this has been referenced both by the Minister of Health in the speech from the throne and in the mandate letter for the Minister of Health, where we're asked to continue demonstrating leadership in public health by strengthening surveillance and capacity in this space. The Pan-Canadian Health Data Strategy is currently in development. We have an expert advisory group that has released 2 fantastic reports highlighting the complex work that needs to happen in terms of governance, in terms of interoperability, in terms of our systems, and in terms of our partnerships and trust with citizens and stakeholders. So that is the high-level roadmap that we are looking towards. It's going to bring us forward. And at the same time, there is a great deal of work on specific systems and looking at the IMIT capacity effect to make sure that we can work effectively with partners.
Mr. Chair, do you have more time? Okay. Quickly, how do you determine how much N95 respiratory stock is deemed an adequate supply, and how is it determined who gets access to that stock?
Mr. Chair, thank you for the question. So as I had mentioned, we worked with our federal colleagues to create a supply and demand model, which looks at a number of factors in terms of information that's shared with us from the provinces and territories. We look at the epidemiology of COVID-19 and that progression, as well as ICU utilization. As well, we needed to account for where there may be changes in policies in the jurisdictions on usage and how they were distributing the masks. So as an example, we did see with Omicron, where there was increased transmissibility, we did see an increase in the utilization of N95 masks. And certainly that helped to inform changes to what we saw as the annual requirements. And so that would change what we saw as our stockpile number. So our 8-week supply based on the height of Omicron. So when we looked in December of 2021, it was in the order of 139 million as an annual for all of the country. So in looking at the 8-week supply, what would be required? When we saw during Omicron increased utilization for the provinces for N95s, while I said we had an 80-20 allocation framework, we did switch to push 100% of the masks coming in immediately out the door to the jurisdictions to help address that need. And as well, where there were N95 equivalents or masks that were not the preference of the health care system because of the requirement for fit testing, we were able to work with the jurisdictions to have a broader distribution within their systems outside of the healthcare sector, so we could maximize the use of those other masks. So those are some of the methods by which we determine the overall amounts, and working with the transparent allocation framework and the ongoing weekly conversations with the jurisdictions at the Logistics Advisory Committee allow us to get the right amounts out to the right areas. Thank you.
Thank you, Ms. Evans. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. I want to thank everyone for appearing here today, and I will just second the comments made by my colleague, Mr. Davies. The lack of ability to answer some of these questions is truly outstanding. As someone that's brand new on this committee, many of the questions that I've seen asked came from the brief that was prepared by the Library of Parliament, and you haven't been able to answer some very simple questions. So I just wanted to make sure that was on the record. To follow up on some of the questions that were asked by Mr. Barrett in regards to whether you looked into the availability to have travel not necessarily only have vaccination, I'm just wondering if you could please provide an answer on that. Ms. Evans.
Mr. Chair, I'll turn to my colleague, Ms. Diogo, with respect to a travel-related question. Thank you.
Thank you. So on the question is whether we are only looking at vaccination. Vaccination is a fundamental element, but we also ensuring that in doing so, we have captured exemptions in the regime to allow for equity concerns and to ensure that people are able to enter Canada when needed. So I hope I answered your question.
Could you please give a little bit more detail regarding the exemptions and what data you guys use to come up with those exemptions?
In terms of exemptions, we keep in mind that vaccination is not available pediatric vaccination, so vaccine. So in the regime, we have allowed for unvaccinated children to be able to enter with parents who are vaccinated. Canada has expanded the list of vaccines that are acceptable to travel to Canada, and we continue to expand that list. The questions about temporary foreign workers, one that we have ensured that vaccination is not a barrier to employers having the help that they need.
So
we have
one question then. What data did you guys use to build those arguments to support the exemptions?
The data used includes previous pilot project that has been done, looking at the testing regime. We look at data in terms of importation data of COVID-19. We've looked at the information related to vaccine availability around the world in other countries.
All right,
so
wonderful. Because we do have a very limited amount of time. Would it be possible to table some of this information with the committee so that we can see the rationale that was used to help formulate the decisions made by PHAC here?
We can certainly table information. It would be helpful to have much more specific
very specifically, I would like you guys to provide in writing a response to the question that was asked by Mr. Barrett immediately before I was able to ask questions.
Okay, Mr. Chair will follow up in looking at the transcript in terms of the question that was asked and ensuring that we provide the information that we have available.
Fantastic. One quick question, because I believe I have about 30 seconds left. Do you have a number of weeks that the stockpile will last? Yes or no?
Mr. Chair, we now have 8 weeks supplies of key commodities and personal protective equipment.
So what was the number prior to this COVID-19 pandemic?
Mr. Chair, personal protective equipment was not a commodity requested of us of the provincial jurisdictions. We did not have an 8-week supply prior to the pandemic.
How many weeks supply did we have prior?
I'm unable to answer that question, Mr. Chair.
Thank you, Ms. Goodridge. And Ms. Evans, Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses. I'd like to start by asking PHAC and specifically Mr. Allison. In the Office of Auditor General Report number 8, the Public Health Agency of Canada, it was recommended that the Public Health Agency of Canada should develop and implement a long-term pan-Canadian health data strategy with the provinces and territories that will address both the long-standing and more recently identified shortcoming affecting its health surveillance activities. The agency agreed to that recommendation, and I believe also the agency created a corporate data and surveillance branch in October of 2020. In the response from agency, and I'm referring to page 48 of Report 8, it was indicated that the long-term strategy is under development and is on track for completion for December 21st. Mr. Allison, are you in a position to be able to give us an update on where this strategy is? What are the short-term, medium-term, long-term objective? Do you have a roadmap that you can share with us with some timelines? Thank you.
Thank you, Mr. Chair. Absolutely. So the Pan-Canadian Health Data Strategy, which I did mention before, is the long-term roadmap that we're looking at. It's been developed in consultation with provinces and territories and being led currently. 2 reports have been published by the expert advisory group. A 3rd report is due in spring of 2020. In terms of the high-level milestones for the group, first, one of the key items was actually the creation of this branch, the Corporate Data and Surveillance Branch. The plan to establish the governance for the long-term Pan-Canadian health data strategy has also been put in place. The launch of the expert advisory group has been put in place. And again, the development is set for April 2022. The short and medium-term priorities that have been outlined under the strategy are being defined by March 2022, and the intent is to bring this to a conference of deputy ministers of health in May of 2022. So the overall work is happening and is proceeding at pace. There are also task-limited time groups that are working on specific sub-items under the Pan-Canadian Health Data Strategy. And if the esteemed members of the committee have not read the first 2 reports, again, they are excellent and do highlight an ambitious but achievable path towards actually having an effective public health data ecosystem and effective sharing across provinces and territories.
Thank you, Mr. Allison. Back to you again, sir. On the following recommendation, 880, the Public Health Agency of Canada should appropriately utilize its global public health intelligence network monitoring capabilities to detect and provide early warning of potential public health threat, in particular clarifying decision-making for issuing alerts. Now, in the response from the agency, naturally, once again, the agency agreed, but they said the agency will work to make further improvement to GFIN and to one of the program components, the alert process specifically, and it continues. Can you tell me why specifically the alert process and what improvement has been done? And do we have any indication that we need to issue any potential alerts?
Thank you, Mr. Chair. And yeah, I was going to pass it over to my colleague, Cindy Evans.
Thank you. Thank you, Mr. Chair, for the question. So there was the external review panel did include in its recommendations that we should include early warning signals currently known as alerts should remain a core function of GFIN's operations. And as I mentioned, that is one of several products that comes out of the GFIN program. So what we have done since the audit was done and since the review is to improve and streamline our decision-making process for the GFIN alerts and other GFIN products and processes. Another, in looking in detail at the report that came from the independent review panel, they did also suggest that we look in terms of the terminology that we're using around the use of alerts and work with international colleagues to make sure there's alignment in terms of the nature of the alerts and the degree that an assessment forms part of those alerts. So we have undertaken some work to bring that clarity, but I think in my view, it was also a nod from the external panel in terms of the importance of early warning in general and events-based surveillance systems and the role that they can play in pandemic preparedness. Thank you.
Thank you, Ms. Evans. Suite, Monsieur Thériault, pour 2 minutes et demie.
Mr. Chair, you have 2.5 minutes. Thank you, Mr. Chair.
Son rapport numéro 10 qui concerne...
In report number 10th, that has to do with medical equipment and PPE, the Auditor General refers to the great risk related to contracts with advance payments. The auditor mentions that measures were taken when the service was not provided to recover those amounts. Can you tell us where things stand in terms of getting these amounts back?
For that question, the questions related to the contracts and advance payments would be best answered by my colleagues at PSPC. Thank you.
Son, Monsieur le Président, donc j'ai pas entendu la réponse.
The sound cut out. I did not hear the answer.
Oh, happy to repeat my answer.
Just one moment, Ms. Evans. It's probably a technical problem on our end, so we'll need to get it resolved, and then we'll start over.
I'll wait for your signal, Chair.
Yep. Yeah, okay. It works now? Ça marche? Okay. Okay, we'll reset the clock, Mr. Thériault. 2 minutes et demi. Allez-y.
2.5 minutes, Mr. Thériault. Go ahead. So I didn't hear the answer. Can she repeat that?
Thank you, Mr. Chair. With respect to the process for advance payments and the contracts, my colleagues at PSPC would be best placed to answer those questions. Thank you.
Collègue, vas-tu répondre à la question ou pas?
Will the colleague answer that question? No, it's another department. Okay. Must have been a glitch with the translation. Now, with respect to the Auditor General's report, we hear that there were problems when it comes to management. Specifically, let me find this here. This stockpile, we're talking about the stockpile. There were problems at the beginning of the pandemic. These problems that existed in 2018 already existed, and they were revealed again in 2018. So what did you set up to address these problems with respect to the stockpile of personal protective equipment?
Mr. Chair, thank you for the question. First, I'd say that the National Emergency Strategic Stockpile, similar to our colleagues in the United States, has seen an evolution in terms of the mandate and the scope of the programming. So certainly from its inception in 1952, where it was focused more on healthcare supplies, there's been an evolution where post the 9/11 crisis, the mandate expanded to look more towards medical countermeasures for chemical, biological, radiological, nuclear. With the post-SARS environment, we looked more in terms of scoping in antivirals, and then its personal protective equipment had not formed a large part of the mandate or need for the National Emergency Strategic Stockpile. Despite this, with the onset of the COVID-19 and the fierce global competitive market that we saw, the federal government leaned forward to do bulk procurement for personal protective equipment, and we're able to actively bring in a significant number. We were able to purchase 3.8 billion units of personal protective equipment to supply the provinces and territories. Thank you.
Merci, Mr. Thériault.
Okay.
Thank you, Mr. Thériault.
Mr. Davies, please, for 2.5 minutes.
Thank you, Ms. Evans. It would be helpful, I think, and I would ask you to undertake to provide the committee with a breakdown by category and number of everything that was in the National Emergency Strategic Stockpile as of December 31st, 2019, and then perhaps a breakdown of what category of supplies the stockpile has now and in what number, and that may help us get the answers we need. Would you undertake to provide the committee with that, please?
Mr. Chair, as part of our National Emergency Strategic Stockpile forms part of our emergency critical infrastructure, and there are a number of holdings that we don't disclose to the public for national security reasons. That being said, in 2021, we did revisit our disclosure policy and looked at the unprecedented COVID-19 response. And as a result, there are some information holdings which may be disclosed. So certainly we could share some of the types and global quantities of the personal protective equipment and medical equipment and supplies that were purchased as a result of COVID-19. We'd be happy to provide that information to the committee.
Well, and when I asked, in answer to my colleague, you made it quite clear that we have 8 weeks of supply now, but I don't know of what. And we had less than 8 weeks of supply before COVID. I don't know of what. Do you know how many weeks, under 8 weeks, we had prior to the COVID pandemic? And you're just unable to tell us, or is that a number you can provide to the committee when you go back and research?
Mr. Chair, with respect to the question, when I speak to the 8-week supply for personal protective equipment, there are 5 key commodities that are quite important for respiratory illness like COVID-19. And so that's N95 respirators, surgical masks, gloves, face shields, and disposable gowns. So we do have over an 8-week supply of those key commodities. We are not able to provide that measure for the pre-COVID environment for the personal protective equipment. And I would add
Sorry,
that
can I ask
burn
why?
rate-
Why can't you? If you can give those numbers now, why can't you tell us what the numbers were for those categories prior to COVID?
With respect, Mr. Chair, I'm unable to provide that number to the committee.
I understand. I'm asking why. Because you have the number and can't, or because it's a national secret, or because you don't know?
Mr. Chair, the supply and demand modeling that was done was very effective, and changes with the epidemiology as well. So it enabled us to, working with the provinces and territories, identify what the national burn rates and needs are, and we did not have that supply and demand model in place prior to the COVID-19.
Sounds like we didn't have any of the supplies in place prior to 2019.
Thank you, Mr. Davies. Thank you, Ms. Evans. Next, Mr. Lake, please, for 5 minutes.
Well, thank you, Mr. Chair. And I'm going to start with a caveat that's all too important these days to mention. So I am pro-vaccination. I've been vaccinated, taken 3 shots of Pfizer. My family's all vaccinated, and I'm glad they are. That said, I, like most people on this in this committee room, would know people who have chosen not to be vaccinated for whatever reason. It might be deep convictions, to use the words of the Prime Minister back in May of 2021 when he said, quote, "We're not a country that makes vaccines mandatory." And I'm curious what advice was given between May of 2021 and 3 months later when obviously there was a course reversed. So did the Public Health Agency give advice on mandatory vaccines versus non-mandatory vaccination? Is there any evidence that the Public Health Agency presented that caused the Prime Minister to change his mind?
Mr. Chair, with respect, officials today are here to prepared to answer questions in relation to the Office of the Auditor General reports. And while the vaccine rollout is part of the Public Health Agency's official role, we don't have officials here today to speak to those broader questions. Thank you.
So again, in terms of evidence on the government policy on mandatory vaccinations versus non-mandatory vaccination, can you get me that? Get us that information in writing?
Mr. Chair, with respect, certainly it wouldn't be our place to speak on behalf of the Prime Minister in terms of the information around the vaccine rollout that was managed by the Public Health Agency in collaboration with provinces and territories. We would be happy to provide key metrics around that program. Thank you.
Perfect. Yeah. So evidence that shows that mandatory vaccination policy, is more effective than a non-mandatory vaccination policy would be helpful. Wondering if there was
Mr. Chair,
any.
if I could just interject, what I said would be available from the Public Health Agency would be metrics around the vaccine rollout program and our ability to work with the provinces and territories to ensure that Canadians had access to vaccine and a description of the rates in Canada. Thank you.
And that's fair. We can call other witnesses maybe that can attest to that. I'm curious about research or advice as to negative effects of a mandatory vaccination policy. Again, mandatory being the key word. No one at this table is debating the effects of vaccines. But was there any research done or any advice given on the mental health effects of losing one's job or maybe losing one's house or even taking a vaccine that someone might believe is going to hurt them, the mental health effects of those things?
Mr. Chair, thank you for the question. So although mental health related initiatives are not managed directly by the Public Health Agency officials that are here today, we can certainly say that mental health and the well-being of Canadians is a top of mind priority for the Government of Canada. And we're aware of the impact that the pandemic has had on the mental health across the population, including those disproportionately impacted by COVID-19. So we'd be happy to follow up and provide specific information writing with the committee that is available to us. Thank you.
Was there any consideration given or advice given regarding an approach that would not have made vaccines mandatory? So I'm wondering if the government had stuck with the May 2021 assertion of the Prime Minister that, quote, "we're not a country that makes vaccines mandatory." I'm wondering if at that point in time the Public Health Agency was providing an evidence-based approach to the government around how to move forward in the vein that the Prime Minister said he was pursuing back in May 2021.
So, Mr. Chair, with respect, at this time, officials that are running the vaccine rollout program are not at the committee today. If there are questions related to the application of vaccine policy in relation to our border measures, certainly Ms. Diogo could undertake to answer those questions. But as I believe I've stated, the broader questions with respect to the vaccine rollout program can't be answered today. And I would add as well, with respect to the choices made by individual provinces in terms of setting their vaccine requirements, certainly we wouldn't be in a position to speak to those issues. Thank you.
Perhaps, Mr. Chair, perhaps we could make sure that we have officials at future studies who can answer those questions at future meetings. I'm interested, how much time do I have, Mr. Chair?
8 seconds.
8 seconds. You know what, I'll cut off there and I'll pursue the rest of my questions in my next round. Thank you.
Thank you very much, Mr. Lake. That's greatly appreciated. Dr. Hanley, please, for 5 minutes.
Thank you, Mr. Chair. And may I ask, first of all, to cut me off at 30 seconds before my time to share that time with Mr. Van Koeverden. I just wanted to indulge.
I can do that, Dr. Hanley, but I will tell you that it does appear that the Liberals are going to get another turn, so he can have 5 minutes in the next slot if you'd prefer. Go ahead.
Okay, then I'll take it back. And just for my members, I will take a few seconds for my members around the table just to give a quick plug to tomorrow's launch of the 44th Parliament's Parliamentary Health Research Caucus. And Mr. Ellis, Dr. Ellis, is co-chair of that caucus. The theme is Game Changers in Health Research and Health Innovation. It's a virtual panel. It's at 4 p.m. I highly recommend you look at your email in for the invitation and attend. Thank you. And next to add my thanks to the witnesses. And I know as someone myself who is in daily contact with either my CMOH counterparts around the country or with public health agency officials, how hard you have all worked. And I think the public may not recognize the role of both public and provincial territorial public officials, public servants in providing that analysis and surveillance information and policy advice and procurement advice, many other roles that enabled us to get through this pandemic with relative success despite the hardships that Canadians have endured. So I just wanted to add my thanks here. One of my questions is around pandemic preparedness as a whole, and when we look at, as an analogy, climate change disasters, for instance, where we are looking at what were once 1 in 500 or 200 or 100-year events are now becoming much more common, and I fear the same may be true of pandemic-level events, and I think these reports are very important to help us build capacity in vital areas of public health protection. So a question perhaps for, through the chair for Ms. Evans, when you look at pandemic preparedness as a whole and given these reports, where do you think the highest priorities are?
Mr. Chair, thank you for the question. In 2017, the Public Health Agency had to work with provinces and territories to create the FPT Public Health Response Plan for biological events, and that would include things like pandemics. We had started in 2019 working with the jurisdictions to put in place an exercise program so we could get into a high degree of detail in terms of testing this program. So we were fortunate to have a very robust initial planning conference in October of 2019. However, unfortunately, COVID-19 arrived, and at the request of the provinces and territories, we were delivering under that plan in real time, and so it was not the time to be doing exercises. And so for us, that'll be a key priority is learning the lessons from COVID-19 and looking at that plan as well as other capstone plans, our Health Portfolio Emergency Response Plan and our Strategic Emergency Response Plan, to see where are any gaps, where do they need to be updated. Secondly, I would say that we are working in concert with our key partners partners across the federal government, including with public safety, the Canadian Armed Forces, Indigenous Services Canada, we agree, we expect that in relation to climate change, we're going to be seeing more natural disasters as well as keeping our eye on pandemic response. So it's incumbent on all of us to look to see what are the upstream activities that we could do working with the jurisdictions, including municipalities as well as Indigenous communities, to both prepare and to mitigate the impacts of emergencies, including in pandemics. Thank you.
Thank you. Thank you. That's very helpful. And following on the discussion, the questions on GFIN and signals and risk assessment, I think perhaps through the chair for Mr. Allison, when we think about risk assessment, and especially in the early days of the pandemic, when the risk was really kind of portrayed as low for quite a long time, what metrics were applied to risk assessment, and how do you think we can learn from risk assessing what turned out to be a highly infectious and rapidly evolving virus with wide geographic spread? We certainly don't want to overcall risk, but we don't want to undercall it either. And I'm really interested in your thinking as we move towards the CIRA, or the Center for Integrated Risk Assessment, what your thoughts are on the metrics and how much we've learned.
As briefly, as succinctly as you can, please, Ms. Evans or Mr. Allison.
Thank you, Mr. Chair. We thank the Office of the Auditor General for flagging this important recommendation. So early on in the pandemic, we had done rapid point-in-time assessments from January to March 2020, which had identified the impact of the virus as low. And our assessments, our risk assessments, were based on the WHO's rapid risk assessment guidance. We did look to update in June of 2020. That rapid risk assessment tool used was revised and updated, and similarly, those improved tools were used to look at the variants of concern, including most recently with the Omicron variant of concern. So we will be working through our new Center for Integrated Risk Assessment at the rapid risk assessment tools. And it's quite critical that we work with provinces and territories as well as our international partners to look for synergy across the methodologies that are used. But certainly we agree that there's work to be done.
Thank you, Ms. Evans. Dr. Hanley, Mr. Lake, please, for 5 minutes.
Thank you, Mr. Chair. Before I do this last round, let me just recognize that the pandemic's been hard on everybody. I recognize how hard all of you are working and have been working for the last couple of years, and that you may not be able to answer some of the questions I ask, but I'm going to ask them anyway because I think they're important to Canadians. So for Mr. Allison, I think you're the Chief Data Officer. I'm wondering if you could point to any data that you have found to back up the Prime Minister's comments in regards to people who choose not to be vaccinated, that, quote, many of them are misogynists and racists. Is there any data to back that up?
Thank you, Mr. Chair. So the work that we're doing in the corporate surveillance and data branch is really work to support the data and analytics and the risk assessments that are happening in other parts of the organization. I'm not aware of any data that we have related to the question.
In regards to communications, we all want, at least myself and I imagine all of you, want to see more Canadians get vaccinated. I'm wondering if there's any evidence to suggest that referring to people who choose not to be vaccinated as misogynists and racists helps to convince them to choose to get vaccinated.
Mr. Chair, with respect, I believe my colleague has already responded to the question in terms of our ability to answer that question. Thank you.
It's part of your job, I imagine, to convince people to choose to be vaccinated. I'm wondering if those comments, if you found those to be helpful in your work to assure Canadians that vaccines are safe.
Mr. Chair, with respect to the vaccination program, as I've stated, the officials who led the vaccine rollout are not at the Standing Committee of Health today. We'd be pleased to speak to the data in terms of the success of the vaccination effort, including most recently through the Omicron aspect of the outbreak in the impacts to hospitalization and to ICU utilization. So certainly if there are specific questions, we'd be happy to do our best to answer those. But as I've stated, officials who lead our vaccine rollout program are not at the committee today. Thank you.
Thank you. We'll look forward to hopefully having them at committee soon. I'm going to pass the rest of my time to Dr. Ellis.
Thank you, Mr. Chair. And just a couple of questions around data again. What are the metrics we're going to use in Canada that would suggest we've moved from pandemic to endemic state of COVID-19? Maybe Mr. Allison, I understand you're the Chief Data Officer for the Public Health Agency of Canada.
Mr. Chair, I'll start that answer, and then if my colleague has additional points to add, I will turn to him. So we've not yet reached an endemic state in Canada.
No, excuse me, ma'am. I don't want to be rude, but I just wonder, tell me what the metrics are. What are we going to use? Just 3 things. Because we know about vaccines, how many people have been immunized, those kinds of things. Just quickly.
In looking at the endemic state, we would be looking at the load on the healthcare system and its resilience to the demands. We would also be looking to be in a position to provide Canadians with clear and sustained communication. So we expect, based on our modeling, that we would enter a transition period towards the endemic state over the next number of months. But the transition is unlikely to be linear, and there remains potential for a resurgence and variants throughout. And certainly our experience with the Omicron variant of concern was a lesson learned for all in terms of being prepared for worst case scenarios.
Understood that. When might we Canadians have access to that plan? Canadians have no idea when this is happening. Canadians don't know anything about the metrics. So when might PHAC roll out that plan for Canadians? Very important. Canadians need some hope. Chair says very quickly, let me have the date.
So the epidemiology of the COVID-19 virus is what will determine when we move to an endemic
Just the plan,
state.
though, ma'am. Just the plan, the date for the plan.
So if you'd like to hear with respect to our border measures, I could ask my colleague, Ms. Diogo, to speak to that. But in terms of, I believe...
So there is no plan?
As I've said, the virus and the epidemiology in Canada will dictate when we have reached an endemic state and when we have some...
No, I understand that, but my question, I know I'm dogging you here, but what I'm asking you is not when you're going to declare it happening. I asked you that, you said you couldn't answer it. When are you going to give Canadians a plan? That's my question, a plan.
That's
Simple.
That's the last question, and then I'll let you to answer it without being interrupted there. Ms. Evans, go ahead.
Well, I'll turn to my colleague, Ms. Diogo, if there is additional detail with respect to the public health measures associated with the border that she would be in a position to share.
Thank you. There is no plan that date of a plan that I can give to the committee, Mr. Chair. What I would say that the Chief Public Health.
I don't need any more.
You go ahead and finish your answer, Ms. Diogo. He doesn't get to decide when you're done.
Okay. The chief public health officer on a weekly basis provide update to Canadians on how Canada is faring against the virus and continue to update on the key metrics that we are monitoring, and that will let us to know whether we are getting closer to the endemic stage and what could be the future in terms of changing the border measures. Thank you.
Thank you. Mr. Van Koeverden, please, for 5 minutes.
I guess we would like in writing that information tabled to the committee, if we could, please, sir.
What information is that?
Just what Ms. Diogo said.
Ms. Diogo, are you in a position to complement your answer with some written materials?
I think, Mr. Chair, what I indicated are the updates that the Chief Public Health Officer provide on the modeling. There is certainly information that has been communicated publicly, and we can make sure that that modeling update is provided to the committee. Thank you.
Thank you. Mr. Van Couverden, please, for 5 minutes.
Thank you, Mr. Chair. I do want to remind every member of this committee that answers appear in the blues. And like if you're speaking while your question is being answered, then it's not just rude, it's also inappropriate to suggest that they provide it in writing after. If you're interested in the answer, then just listen to the answer. I also want to thank the witnesses for your patience today. I apologize that this meeting has gotten to the point that it has. I have a question for my colleagues, not for the witnesses. If you'll indulge me, for unanimous consent, I'm raising a motion that pursuant to Standing Order 108-2, the committee invites the Minister of Health, the Minister of Mental Health and Addictions, and Associate Minister of Health, as well as officials, to appear for 2 hours regarding the 2021-2022 supplementary estimates, C, and the 2022-2023 main estimates, and the 2022-2023 departmental plans for the Department of Health, the Canadian Food Inspection Agency, the Canadian Institute of Health Research, and the Public Health Agency of Canada, and the meeting take place on Monday, March 21st, 2022. Monsieur Thériault, voulez-vous dire en français encore? Parfait.
Okay, colleagues, there's a request here for unanimous consent. If unanimous consent is not forthcoming, this motion really isn't up for debate because it hasn't provided the requisite notice. So if we have unanimous consent, we can deal with it now. If we don't, we'll consider it notice of motion, and it can come forward at a later date.
Just a point of order, Chair.
Yes.
If Mr. Van Couverden, through you, could indulge me and just repeat the list of witnesses one more time, but I don't suspect that or expect that unanimous consent will be withheld.
I'm happy to. The committee invites the Minister of Health, the Minister of Mental Health and Addictions, and the Associate Minister of Health, which is 2 people, not 3, for the sake of clarity, as well as officials to appear for 2 hours regarding the SEPs and the main estimates on March 21st for 2 hours.
Do we have unanimous consent with respect to that motion, or shall we take it as notice? I see heads nodding around the room. Monsieur Thériault, êtes-vous d'accord?
Mr. Thériault, do you agree?
Je suis pas d'accord.
I don't agree.
We'll take it as notice of motion. Go ahead, Mr. Van Couverden.
Thanks. I'll table it in both official languages after the meeting. Over to the meeting at hand. Apologies for the delay. My question is regarding health data collection. My first question is with respect to the health data collection being supposedly inadequate according to the Auditor General's report. First, to the Auditor General, could you be specific with respect to what areas require improvement, please?
Thank you for the question, Mr. Chair. I would start with saying that it is important to update and to ensure that the agreements between the federal government and the provinces about data sharing are effective. Secondly, ensuring that there's an information system that is capable of collecting and storing all of the information from provinces that is required to be able to oversee and act in response to the pandemic is also important. And finally, as we mentioned in our report, testing these systems and plans, agreements to make sure that they operate effectively and that the resources needed are there would be another important step.
Much. Secondly, I'm just curious from the perspective of Public Health Agency of Canada. Today we've touched on, and I suppose over the last 2 years, we've all sort of become experts on healthcare jurisdiction. I'm curious to know how the agency has worked with provinces and territories to provide additional support, and how we can look toward more supports in the future in various and specific ways. I'm thinking of long-term care, but particularly others from your perspective that are most important to ensure the resilience of our healthcare system on an ongoing basis.
Mr. Chair, thank you for the question. We have been actively engaged with the provinces and territories, as well as Indigenous and municipal governments. During the COVID-19 federal response, we put in place a single window with the Public Health Canada to reach out to us in terms of the surge supports that would be available to them. We had over 150 operational calls with the jurisdictions to help them get access to the resources that were available to them. And that can include things like contact tracing supports. It could be supplies from the National Emergency Strategic Stockpile. As well, we were able to deploy epidemiologists. So just as an example, we were able to send epidemiologists to James Bay area region that had several First Nations communities, including Kasheshawan, which saw over 10% of their population infected and several residents requiring hospital interventions. We also, the government put in place a safe voluntary isolation sites program, and that allowed for over 60 isolation sites in 47 communities to be funded, which supported over 17,000 individuals. So these are the type of activities which help to break transmissions. One of the key learnings for this has been the ability to work with the jurisdictions, but also to put innovation and virtual supports in place. So the contact tracing, for example, we were able to support the programmings with virtual call center supports, and similarly able to support the jurisdictions with remote epidemiological outbreak management. So quite a number of areas where we're able to work in concert with the jurisdictions. I think gains that have been made in terms of infection prevention and control programs as well has been another area where we've not only had an opportunity to step into an outbreak, but also to help them lay a path forward in a number of areas to put key programming in place that would help mitigate further infections. Thank you.
Thank you, Ms. Evans. Colleagues, we started 5 minutes late, so I propose to give Mr. Thériault and Mr. Davies a turn and then ask for adjournment at that time. I hope that's okay. Mr. Thériault, 2 minutes et demi.
2.5 minutes, Mr. Thériault. Thank you. You'll realize that my refusal had to do with form and not substance, and that we'll see it in 2 days, this motion. Now, still with respect to this management of the stockpile, in the measures taken to rebuild the stock or stockpile or inventory, do you favor local providers?
Mr. Chair, thank you for the question. What I think has been important in the COVID-19 response is where we've seen a fierce globally competitive market, the benefits of having domestic supplies available to the jurisdictions. And so in a number of areas, we are now well situated, for example, with N95 respirators with domestic manufacturing in Canada. So we saw manufacturers leaning forward with the call from the federal government in terms of supports needed.
Yes, but do you favor local providers? Yes or no? Over others? Yes or no?
Mr. Chair, I'm unable to answer that question with respect. We would follow the appropriate procurement policies, and if there is more detailed response required, then I would have to defer to my colleagues at PSPC. Thank you.
I'm sorry, Mr. Chairman, we've lost the translation, says Mr. Thériault. There was no translation on the last part of her answer.
Is it working now?
Ça fonctionne-tu? J'entends très difficilement. Si vous parlez dans le micro, oui.
Yeah. Yeah. Okay, Ms. Evans, could you answer?
Thank you. Mr. Chair, I'm unable to answer that question as it's posed, but what I can say is that domestic
Okay, perfect. Thank you. Sorry. If you can't answer, I'll ask another question. Okay. So to avoid the recurring problems with respect to these stocks that are past due and the alienation of these stocks. What do you do proactively to manage things? In other words, if so, are you envisaging using up these resources through our healthcare systems rather than throwing things out, rather than waiting until they're past due, or to use them up by providing them to charitable organizations? Can you at least answer that question?
Mr. Chair, thank you very much for the question, and the members raised an important issue with respect to the life cycle management of products through the National Emergency Strategic Stockpile. So certainly our first line of deployment is to the provinces and territories for use within their healthcare systems. But where we see that stocks may expire before we're able to deploy them, we would follow the policies that are laid out by the Treasury Board in terms of appropriate divestment and deployment. So we would, for example, look to transfer to other federal departments, usually through the Government of Canada surplus. We have an ability to sell them at fair market value. As well, we look to do donations to other levels of government and recognize charitable organizations. So that's another opportunity for a broader reach within Canada to make sure that the supplies can be effectively used. And conversion to waste using the most environmentally sustainable method possible would be the choice that would be made following an attempt to look at all of the other avenues for effective use within Canada. Thank you.
Thank you, Ms. Evans. The last round of questions will come from Mr. Davies for the next 2.5 minutes.
Thank you, Ms. Diogeo or Mr. Allison. In January, the WHO Director General noted the following, quote, "No country can boost its way out of the pandemic, and boosters cannot be seen as a ticket to go ahead with planned celebrations without the need for other precautions." Last month, the European Medicine Agency said that there was still no data supporting the need for a fourth COVID vaccine dose. They further stated that even if multiple boosters do prove to be necessary, they would need to be spaced out in the style of annual flu jabs rather than delivered every several months. And finally, they warned that overly frequent booster doses could potentially lead to, quote, "problems with immune response," end quote. As Canadians near the end of the third booster program, what is the plan to deal with COVID-19 going forward? Mr. Allison or Ms. Jojo, and if you can't answer, that's fine. I'm not sure if it's beyond your scope.
Mr. Chair, as my colleague mentioned earlier, the representatives who are responsible for the vaccination program are not here. So unfortunately, we will not be able to respond to that question. Thank you.
Fair enough. My last question will be, I'm confused because unless I heard improperly, Ms. Evans stated that a warning was issued by GFIN on December 30th of 2019, yet the Auditor General's March 2021 report found that Canada's GFIN failed to issue an alert to provide an early warning of the novel coronavirus, and even studied, I'm reading from a July 30th Globe and Mail article that said that Canada's Auditor General is planning to investigate what went wrong with the country's once vaunted early warning system for pandemics after the unit curtailed its surveillance work and ceased issuing alerts more than a year ago, raising questions about whether it failed when it was needed most. And they said that according to 10 years of documents obtained by the Globe and Mail, the system went silent on May 24th, 2019, after issuing more than 1,500 alerts. To the Auditor General, did you find any alert issued by GFIN in December of 2019 about COVID-19?
No, we did not. We found that they were doing their daily reports, but they did not issue an alert, which is a different kind of warning system.
Thank you, Ms. Evans. Did I misunderstand you? I want to give you a chance to clarify that. Did you say that GFIN did issue an alert on December 30th? I know you said it wouldn't have made a difference, but...
Mr. Chair, thank you for the question. As I stated earlier, and I'm happy to restate the answer, there are a number of different products that come out of the GFIN program, one of them being the GFIN Daily Report. And what I had stated is that the GFIN Daily Report did identify the cases of mysterious pneumonia later identified as COVID-19, and that early signal to senior management galvanized the system immediately.
Can you tell us why an alert wasn't issued then?
Thank you. By December 31st, the significance of the event was clear in the public health surveillance community. and partners internationally are already aware of the signal. There were other event-based surveillance systems who had issued similar to the GFIN daily report on that same day. And the external independent panel had identified that there would have been no opportunity for the GFIN to identify the signal earlier than it had. But absolutely, in the daily report from the GFIN on December 31st, that signal was identified to senior management within the agency, which immediately galvanized our response from the very beginning of 2020.
Thank you, Ms. Evans. Thank you, Mr. Davies. That concludes our questioning. To all of the witnesses, thank you so much for being here. Thank you for your patient professionalism. We understand that many of the questions that were posed probably should be posed to other officials within your department. We will endeavor to identify them and have them come back and pose the same questions. But we absolutely appreciate the work that you do. We appreciate you being here and for the professional and patient manner you've dealt with the questions. So thank you so much for being with us. We are ready for a motion for adjournment. Is it the will of the meeting that we do now adjourn? By consensus, the meeting is adjourned. Thank you.